Hello friends, this is about polycythemia. Polycythemia is defined as an increase in hemoglobin above normal. This increase may be real or only apparent because of a decrease in plasma volume, which is called spurious or relative polycythemia. The term erythrocytosis may be used interchangeably with polycythemia, but some draw a distinction between them. Erythrocytosis implies documentation of increased red cell mass, whereas polycythemia refers to any increase in red cells. Often patients with polycythemia are detected through an incidental finding of elevated hemoglobin or hematocrit levels. Concern that the hemoglobin level may be abnormally high is usually triggered at 17 gram per deciliter for men and 15 gram per deciliter for women. Hematocrit levels of more than 50% in men or more than 45% in women may be abnormal. Hematocrit levels of more than 60% in men and more than 55% in women are almost invariably associated with an increased red cell mass. Given that the machine that quantitates red cell parameters actually measures hemoglobin concentrations and calculates hematocrit, hemoglobin level may be a better index. Patients with polycythemia may be asymptomatic or experience symptoms related to increased red cell mass or the underlying disease process that leads to the increased red cell mass. The dominant symptoms from an increased red cell mass are related to hyperviscosity and the consequent thrombosis, both venous and arterial, because the blood viscosity increases logarithmically at hematocrit levels of more than 55%. Manifestations include neurologic symptoms such as vertigo, tinnitus, headache, and visual disturbances. Hypertension is often present. Polycythemia vera is a chronic myeloproliferative neoplasm in which most patients have a JAK2 mutation. So the JAK-STAT pathway becomes constitutively active and the bone marrow produces too many RBCs and often also WBCs and platelets. Patients with polycythemia vera may have bleeding features because of dysfunctional platelets, thrombosis features because of increased red cell mass and consequent hyperviscosity, and aquagenic pruritus, which is itching after bathing generally with warm or hot water because of abnormal myeloid proliferation, leading to abnormal activation of mast cells or basophils, leading to increased cytokine or histamine release. Bleeding features may be easy bruising, epistaxis, or bleeding from GIT. Thrombosis features are digital ischemia, Budd-Chiari syndrome, or hepatic or splenic mesenteric vein thrombosis. Polycythemia vera patients also have hepatosplenomegaly. As the disease progresses, the abnormal marrow can develop fibrosis and becomes less effective. Blood cell production shifts outside the marrow, especially to the spleen. This extramedullary hematopoiesis produces splenomegaly. There is also increased destruction of abnormal blood cells in the spleen, contributing to enlargement. The liver can also become a site of extramedullary hematopoiesis, and this leads to hepatomegaly. Also, polycythemia vera can cause portal or hepatic vein thrombosis, leading to portal hypertension, leading further to congestive splenomegaly or hepatomegaly. Peptic ulcer disease is also common. Physical examination usually reveals a ruddy complexion, which is a predominantly red appearance of face or skin due to increased RBC mass. Splenomegaly favors polycythemia vera as the diagnosis. The presence of cyanosis or evidence of a right to left shunt suggests congenital heart disease presenting in the adult, particularly tetralogy of Fallot or Eisenmenger syndrome. Increased blood viscosity raises pulmonary artery pressure, and hypoxemia can lead to increased pulmonary vascular resistance. Together, these factors can produce cor pulmonale. Features of the clinical history that are useful in the differential diagnosis include smoking, currently living at high altitude, a history of diuretic use, congenital heart disease, sleep apnea, or chronic lung disease. Um, Diuretic use can lead to spurious polycythemia due to a decrease in plasma volume. Sleep apnea leads to chronic intermittent hypoxia, leading to increased erythropoietin and hence to increased hemoglobin or hematocrit. While awake, the patient has normal oxygen levels. It is also important to inquire about the use of testosterone, erythropoietin, and SGLT2 inhibitors, which is gliflozins. Testosterone leads to increased erythropoietin production and suppression of hepcidin, leading to more iron being available for erythropoiesis. SGLT2 inhibitors cause blockade of the SGLT2 mediated sodium glucose reabsorption from proximal tubule of kidney. The associated osmotic diuresis, along with the sodium glucose loss in urine, causes decrease in plasma volume and the consequent rise in hemoglobin or hematocrit. Also, SGLT2 inhibition leads to improvement in oxygen availability in kidney and hence to increased erythropoietin production, leading to polycythemia. Polycythemia can be spurious polycythemia that is related to a decrease in plasma volume. It is also known as Gaze box syndrome. It can be primary polycythemia, which is not mediated by increased erythropoietin production, or secondary polycythemia, which is mediated by increased erythropoietin production. This increase in erythropoietin production can be either physiological response to tissue hypoxia or to an abnormal overproduction. Tissue hypoxia can occur in lung disease, high altitude, carbon monoxide poisoning, or high affinity hemoglobinopathy. Abnormal overproduction can occur in erythropoietin producing neoplasms like hepatoma, uterine leiomyoma, renal cancer or cysts, and cerebellar hemangiomas. Cerebellar hemangiomas present with localizing neurologic signs and symptoms rather than polycythemia related symptoms. A rare familial form of polycythemia is associated with normal erythropoietin levels but hyper-responsive erythropoietin receptors due to mutations. Rare hemochromatosis HFE mutations may have elevated hemoglobin levels. Approach to polycythemia. When we see elevated RBC count, hemoglobin or hematocrit, first step is to search for earlier CBC that might suggest the chronicity of the increase. If no prior elevation is there and patient is asymptomatic, repeat the studies in 1 month. If prior elevation is present or the patient is symptomatic, or if the elevation is substantial even without a prior elevation, obtain a serum erythropoietin level if patient is not hypoxic. That is, oxygen saturation is more than 93%. If erythropoietin levels are low or unmeasurable, the patient most likely has polycythemia vera. A mutation in JAK2 can be found in 90 to 95% of patients with polycythemia vera. Many of those without this particular mutation have mutations in exon 12 of JAK2. Another rare mutation in polycythemia vera is LNK mutation. If erythropoietin levels are low, check for these mutations and also perform an abdominal ultrasound to look for splenomegaly. Tests that support the diagnosis of polycythemia vera include elevated WBC count, increased absolute basophil count, and increased platelet count. In practice, many physicians order erythropoietin levels and assessment for JAK2 mutations at the same time. If erythropoietin is low and polycythemia vera is ruled out, there can be possibility of hyperresponsive erythropoietin receptors due to mutations in them. If serum erythropoietin levels are elevated, one needs to distinguish whether the elevation is a physiological response to hypoxia or related to autonomous erythropoietin production. Patients with hypoxia, that is oxygen saturation less than 92%, should be further evaluated for the presence of heart or lung disease if they are not living at high altitude. Patients with normal oxygen saturation who are smokers may have elevated erythropoietin levels because of carbon monoxide displacement of oxygen. If carboxyhemoglobin levels are high, the diagnosis is smoker's polycythemia. Such patients should be urged to stop smoking. Those who cannot stop smoking require phlebotomy to control their polycythemia. Patients with normal oxygen saturation who do not smoke either have an abnormal hemoglobin that does not deliver oxygen to the tissues, which is evaluated by finding elevated oxygen hemoglobin affinity, or have a source of autonomous erythropoietin production. Further workup is dictated by the differential diagnosis of EPO producing neoplasms. Hepatoma, uterine leiomyoma, and renal cancer or renal cysts are all detectable with abdominal pelvic CT scan. Renal artery stenosis can also cause increased erythropoietin production and also should be ruled out. Cerebellar hemangiomas may produce erythropoietin, but they present with localizing neurologic signs and symptoms rather than polycythemia related symptoms. If erythropoietin producing tumors are also not found, there can be abnormalities in the oxygen sensing pathway in the kidneys. When oxygen is normal, HIF, which is hypoxia inducible factor, is hydroxylated and then degraded in kidney. PHD2 encoded by EGLN1 gene hydroxylates HIF1 alpha, and then VHL encoded by VHL gene recognizes this hydroxylated HIF1 alpha, leading to its degradation. Mutations in EGLN1 gene or VHL gene lead to HIF1 alpha being migrated to nucleus, leading to increased erythropoietin production. Polycythemia due to VHL gene mutation is called Chuvas polycythemia. Also, there is HIF2 alpha, which also increases erythropoietin production in response to hypoxia. HIF2 alpha is encoded by EPAS1 gene. Mutations in EPAS1 gene leading to increased HIF2 alpha activity causes increased erythropoietin production, leading to polycythemia. If the red cell mass is normal, that is less than 36 ml per kg in men or less than 32 ml per kg in women, the patient has spurious or relative polycythemia. That is, actually there is no polycythemia and there is only a decrease in plasma volume. Ideally, one would document the presence of an increased red cell mass. However, the dependence of this technique on radio-labeled red cells has led to its abandonment. Thank you.